Hi, I'm Dr. Andrew Rosen. I'm a psychologist.
And I am Dr. David Gross, psychiatrist, and we are Two Shrinks and a Mic. For today's podcast, we're going to continue a discussion on mental health issues. As those of you who have listened to previous podcasts, you know that we've talked about various diagnoses, treatment approaches, and to a small extent, some of the challenges that are present in obtaining mental health care. But today we thought we would talk about the obstacles to obtaining mental health care. One of the core ones is a concept in psychology entitled resistance, issues inside of an individual that get in the way of being able to proceed with care. And so we'll be talking about a number of these topics today.
Yeah, the term resistance was originally discussed in traditional psychoanalytic theory, and it was based on the premise that people have a hard time in many different ways opening up and actually getting in touch with the reasons for their problems, and even in some cases have a hard time appreciating the need to change and to deal with their problems. So there's many forms of resistance. It really becomes very obvious when you look at some statistics. A number of decades ago, actually, they did some pretty good evaluations and studies of what happens when people decide to go for therapy, and they used mental health clinics to get data. And amazingly, the percentage of people who actually called for information to a center about getting treatment and then actually made an appointment, the ones that actually came to the first appointment, the percentage was very low. And the whole point of that was to demonstrate that people can have a desire for help and to receive treatment, but somewhere along the line after that initial decision to get help, things drop off. And the reasons for that are many. It comes from shame, embarrassment, fear, and the unknown, the fear of the unknown. What happens when I go for help? And who am I going to open up to? How can I trust that I'm going to talk to somebody that I don't know? And it's embarrassing to talk about things that are very private. We're traditionally trained not to share dirty laundry. So there's a lot of reasons why there are resistances to getting help, and amongst other reasons, practical ones, financial ones, et cetera. But psychological resistance is a very powerful issue, and we as mental health professionals are facing that every day, and we try to help people overcome resistance.
Our species is known to be socially interactive and outgoing. I mean, everybody talks about the importance of social contact, social interactions. But if you think about it, we're all sort of private in terms of self-thinking, self-talk, and the thoughts that we have in our heads oftentimes get in the way. And for example, if a person experiences worry, anxiety, there's a lot of self-talk that will be involved in I must be unique in having these experiences. How can I share it with anybody? They're going to look down upon me. And oftentimes it's a self-talk that gets in the way in the ability to acknowledge the need for a problem. In addition to that, there's issues related to family. Depending upon how you've been raised by your family, a lot of families will want to minimize emotional difficulties. I'll often hear people say that, I came from a family where emotions were not allowed, and you had to behave and be proper and be respectful. But if you show emotions, that's a no-no. Then there's the difference between sexes. The men are from Mars, women are from Venus concept, where men tend to be a bit more non-emotional and put things into categories, and women tend to show feelings more openly, which may be one of the reasons why I think women may be more in touch with problems with anxiety and depression and come for help more than that. And if you look at the data suggests that the incidence may be greater in females, but a lot of it may be because they go for help and ask for help. There's a certain amount of, I've got to be macho, I've got to be in charge, take care of myself in the male ego that gets in the way. But this resistance is a problem, and it oftentimes the mental health professionals will approach it by saying, if somebody does come into our waiting room and our consultation room, the initial sessions will be just a plain talk and not put too much pressure on the individual to open up, because clearly what has to happen in the beginning of any kind of therapeutic interaction is the development of some trust, the belief that the individual who you're working with, the mental health professional, is going to have some unconditional regard and not judge you, and it's a good listener. And so a lot of this is what the initial stages of therapy need to be all about, and it helps promote the ability to talk about problems.
I'm kind of reminded of one of my favorite comedians, Sebastian Maniscalco. He has this routine where he says, young people today, they're very often either in college or after college, they say they're going to take a year off and find themselves. And he said, if I told my father that I was going to go find myself, he'd say, find yourself. I see you. There you are. You're right in front of me. So some cultures, and definitely historically, men in particular, were not supposed to find themselves. That wasn't something that was encouraged, and it was actually made fun of. So there's a lot of different reasons for resistance, and some of it relates to the concept we've talked about a bunch of times already, and that is, if you go see a mental health professional, what does that really mean? Does that mean there's something wrong with me? Does that mean I'm defective? And I can't begin to tell you how often people will say to me, even if they're well into the therapy sessions, they'll say to me, I have something to tell you, but I think you're going to think I'm crazy. So, even if they're saying it in jest or sort of funny, it's an underlying issue that there are certain things that we all carry around with us that probably we will think somebody would think we're crazy to be thinking, or to believe, or to behave like. So who wants to admit to another human being our faults, our defects, our problems, our behaviors, if we think that they're either deviant or crazy or weak or in some way embarrassing? So resistance is always there. It's not something, as people who treat people, it's not something we get rid of. It's not like after X amount of sessions, the person doesn't have this resistance. The resistance stays. It's just a matter of how much of an obstacle it is to getting to what we might call the truth of a person.
Previously we spoke about the concept of psychological trauma, and that's a good example of what you're talking about, because individuals may be talking about their marriage or problems with their job or anxiety or issues with mood, but it may not be until the 10th or the 12th or the 13th session that they may open up and tell you about the trauma that he experienced, because of how painful it is to even talk about, or how well protected it is in the brain. That the concept of self-protection and repression is related to resistance, and you often will not hear about traumatic episodes until a person is comfortable enough so that their brain almost releases some of the memories that were held onto so tightly. It also reminds me of what I see commonly in the office, which is if somebody's talking about a painful life experience and they start to become tearful, they frequently will say, well, I'm sorry. They'll apologize. And, I'll look at them a little bit dumbfounded and say, you're allowed to be human. And people forget about, the natural human qualities that we all have. And getting weepy and tearful over painful emotions is not unusual and not abnormal. Individuals who come in to see us, I compliment them on the fact that they've come into the office, so half the battle is already won, and that they've recognized that there are issues they want to address, and that's 50% of the goal of recovery. It's the old saying, how many psychiatrists or psychologists does it take to change a light bulb? Well, the light bulb has to want to change. So it's not how many psychiatrists or psychologists or how good they are, but the individual has to be motivated. And sometimes, and I'm sure you've had the same experience as I have, as we see adolescents whose arms are twisted to come into our office by their parents, they're certainly not happy to be there. And so our challenge is to establish a rapport so that they can trust us and see that we're not there to judge them or to give them a hard time or to represent their parents. We're there really to be their advocates. And once they begin to have that belief, they can begin to utilize the sessions for themselves.
Yeah, no matter what, there's shame, there's embarrassment, there's a feeling of subjugation to this authority figure. There's all kinds of things that are automatic and not even all conscious on the part of the person who's coming in. But we all know that if you cry, you're being weak and you're a baby. I mean, we know that. So if we're told that over and over again in childhood and even in adulthood, why are you crying? Oh, come on, toughen up, be a man, get strong. These are all things that people have built into their psyche, and they affect the person's ability when they do come for treatment to just really, really open up and get to the core of who they are. And in many cases, the person doesn't know really the core of who they are because they've tried to repress it for so long. So it's a process. I learned in my psychoanalytic treatment training that therapy is like peeling an onion. You sort of have to go one layer at a time. And if you don't go at all through the different layers, well, you've pretty much had what we have called in the past just kind of chit-chat therapy. And if you go too fast, you can really do some damage because people get scared and they feel embarrassed or they feel ashamed or they feel frightened, and then they flee treatment. And that's a kind of a different form of resistance. But by and large, people want to get better. They want to get healthier. They want to have their problems reduced. They want to enjoy life more. But the process of doing it is scary. Similar, the parallel would be going to the doctor for a medical problem. People want to be healthy. They don't want to be sick. They don't want to have disease. But it's scary to go to the doctor. So how many times do we hear about somebody goes to the family physician and they don't tell the doctor all their symptoms? They keep some to themselves. They hide some of them because they're afraid to deal with them. Well, it's the same thing in mental health treatment. Patients come in, but they don't tell you everything because they're afraid to deal with it or they're embarrassed about it. So we as clinicians have to be very respectful of that and aware of it as we work with the people.
One of the things I learned a long time ago in working with people who are suffering and experiencing depression, anxiety, life difficulties, et cetera, is that you can't recover from illness until you give yourself permission to be sick in the first place. And even though it sounds like a silly concept, think about it for a second. If you have a strep throat, go to the doctor, your throat kills you, you have some fever, you feel terrible, do a test and clear enough is strep throat, you have no difficulty giving yourself permission to be sick. But if you have anxiety or depression, that's another story. Because remember, we talked about a number of podcasts ago about some of our Judeo-Christian belief systems in modern society based upon the thinking of John Locke, which is the concept of free will. And much of our modern thinking, even though we've been to the moon, we have computers and artificial intelligence and all this fancy stuff, is that we have free will to do anything we want. Well, I couldn't hit a home run if I tried. And that's not because of not trying hard enough. It's just that my brain is not the kind of brain that will allow me to develop a good enough swing to hit a home run. Perhaps if I'd practiced for several years with a trainer, I could, but...
You should have told me. I would have helped you.
But that's not the case. So the reality is that we have some degree of willpower, but we also have limitations. The same way that, when both of us see individuals who've had psychological testing and IQ testing, and, they see the individual gets their results and they see that there are areas where there are deficiencies, but it also means that there are areas where there are strengths. And part of our job as mental health professionals is to take a look not just at the weaknesses, but the strengths, and try to promote the strengths, but also let people know that this concept of willpower is overbaked. It's just not realistic, that you can, long as you can actualize your potential, which is an old psychological term by a famous psychologist, that's the best thing you can do. I've seen young people in high school have come in with depression and anxiety and disappointment in their grades because they worked so hard to get an A. They came home and their mother or father said, "How come you didn't get an A+?" Rather than getting complimented on getting the A. Or if they worked real hard and they got a B, be congratulated for getting the B. If you didn't work and you got a C or a D, that's another story. But unfortunately, we have a society that tends to emphasize willpower and accomplishing things sometimes greater than one's capabilities. And now that we're in the era of social media, we've got kids who are dealing with how many likes they get on TikTok or Facebook. I mean, that's a Boy, that's a tough situation. I mean, when I was a kid, the only thing I got were pen pal letters, and that was my reward for interacting. But um, uh, our job is to help individuals understand that human beings are not perfect, and that being imperfect is the norm and not the abnorm. Experiencing depression is not that abnormal. Having anxiety is not that abnormal. And recognizing that you're coming in to take care of it is really important first step.
So one of the first things that I know we do is help people, as you say, deal with the fact that as far as we know, we're all human and we all have imperfections, and some people have imperfections in area A and some people have them in B or C. And the reason why you're here in my office right now is because you're a human. Life can be very complicated sometimes. It gets to be very difficult and sometimes tragic. And not always are we capable of dealing with it without experiencing pain and symptoms and such as anxiety and depression, and even feeling like ill-equipped to figure out how to deal with things or move forward. So that's why you're here in my office. And even if it's embarrassing, even if you feel ashamed, even if you feel mad at yourself that you need to be here, you're here. And so we're going to make the best of it by acknowledging these things and trying to remove as much of the resistance that you have in the process so that we can really make this thing better and actually quicker. The less we have resistance in the way, actually, the more we can make this process a quicker one and a healthier one. So we have to address resistance, and many mental health professionals don't do that. They just don't talk about it. They just hope that it goes away, or they try to go around it. And those are some of the reasons why people drop out of therapy early. You know, where'd that patient go? Well, you know, whether it's 3 sessions or 10 sessions, there wasn't an awareness of the resistance factor. So the people decide, you know, I got to get out of here. And typically they just don't show up, or they don't make a next appointment, and they disappear. And the main reason is the resistance factor was too much, and it was easier for them to avoid getting help than to go through the process. We all have resistance.
Yeah, and emotional pain is as severe as physical pain, and many of the individuals you describe, who I've seen as well, will sometimes not come back because they talk about the emotional pain being too great, and it's just it's easier to duck and hide than to deal with it head on. And many of these individuals will ultimately come back at a future point and address it head on. But another area of obstacle to adequate care and resistance is an area that gets me into trouble as a psychiatrist, because a lot of what I do is to deal with the biological medical aspects of mental health issues or prescribing medications. And we've talked about this before, but a lot of people that I'll see will come in and will just seek a quick fix. You know, give me a medication to make me better. Where the reality is that maybe medication could help, but attending to either the life issues they have or helping them recognize that they've got a number of maladaptive personality traits, defense mechanisms, psychological factors over the years that have gotten in the way that they have to work on in psychotherapy, talking therapy. But we've got a society, like a lot of other Western societies, that's looking for a quick answer and a quick fix. And that's tough. And then I'll see this very, very often when somebody comes into my office with an anxiety disorder where they have lots of worry and overthinking and catastrophic thinking and maybe even panic attacks. And I'll tell them that, you know, the approach to this, the ideal approach really is a specified type of therapy called, as we've said before, cognitive behavioral therapy. Medication can help, and oftentimes combining the medication with the cognitive behavioral therapy can assist each other. But individuals have to be willing to retrain their brain, and going for the quick fix with a pill, you'd like it to be the case, but it unfortunately most of the time it's not. There are disorders where medications make a big difference, but even in attention deficit disorder, which we've talked about before, you can get on a medicine for that, which will help your attention concentration. But it's kind of like if if you want to get more of a performance out of your race car, you can tune the engine up, but if you don't know how to shift the gears, you're not going to get the power. So likewise, you can take a medication for attention, concentration, distractibility, but you still have to work on time management, organizational abilities, and work on the secondary psychological impact of having ADHD for a number of years before it was recognized that it had an impact upon self-confidence, beliefs in your academic abilities, et cetera. So I will often let individuals know that, you need to pursue the talking therapy aspect of care in addition if you want medication too. And then it develops another area of that's an obstacle, which is not everybody can afford talking therapy. And a lot of people will say, I want to use my insurance company, and then they have to find out if they've got a specialist within the insurance company who could take care of the particular problem they have. And you really never really know for sure if you're getting somebody who is that kind of card-carrying expert in that particular area. So, the whole insurance regime has changed mental health care for the last several decades. I know in psychiatry, I can't prescribe a medication without then having to do an authorization with the insurance company, which could take days and paperwork and require appeals and lots of hair pulling. But that's a separate obstacle that I'm sure we'll be talking about later.
There's the opposite end of the spectrum on the issue you just talked about with medication, and that is some people have resistance to taking medication to begin with. They see medication as either an indication of I'm really sick, I'm really defective, or they see it as a sign of weakness, or they see it as the silver bullet model, or they see the dosage amount as an indicator of I'm really not doing well if I need a higher dose, et cetera, et cetera. And doctor, how fast do you think I'll be able to get off the medicine? And so, there's a natural resistance on that end as well to taking medicine. And what I often have to do, and you do as well, is to say, look, this isn't a function of your personality. There's something going on in your nervous system, your brain, in this particular case, which is just another organ, just like if it was your liver or your heart. And sometimes medication is used to help the process along. It's not an indicator of how crazy you are or something like that. So you have to be aware of resistance on both ends. People are afraid to do the things that they need to do to get better. More so, I believe, in mental health than in other areas of medicine, unless you're telling somebody, they need some kind of major surgery. And then the fear mechanism is obviously there as well.
You just reminded me of the value of the cases that you and I have worked on together, because the reality is most psychiatrists who will work with the therapist knows the individual more intensely than the psychiatrist. Think about it. Most therapists will work with somebody once a week, and psychiatrists who get involved or taking care of medication may see somebody once a month or once every 3 months. And so many times I've relied upon you helping out with a patient who has reluctance about medication to help reassure them that it doesn't mean that they're impaired or sicker than they should be, or that the medication is going to take their personality away or change them as an individual. But the reality is much of the time the individual will have a greater initial trust in the therapist than in the psychiatrist. And that's okay. I mean, that's the nature of the situation. Unfortunately, it's not uncommon for the psychiatrist and the therapist not to communicate. And that's a problem.
We do all the time.
We do all the time. Well, that's because we're talkative. But, that for me to be able to call you up and say, what do you think about Joe Schmo or Jane Schmo and what's going on with them is helpful for me. And likewise, you'll do the same thing with me. And the nature of private practice in mental health care is unique in that, if you're an internist, you'll see patients in your office, but you'll make rounds in the hospital, and you're not isolated. But mental health care for professionals is relatively isolating. You're in your consultation room 6 to 8 hours in the day, seeing individuals, and you don't necessarily get out. And so it's an isolating type of experience. And so the importance of reaching out to talk with another mental health professional who's involved in the care of your patient is absolutely critical and very important. And I know it's helped both of us over the years. And one of the reasons we've been excited about having a team of mental health professionals that we work with together at our centers is the fact that we're able to meet regularly and talk about cases and share both clinical problems, but as well to reinforce each other. I mean, being a mental health professional is not an easy job. There are stresses involved. You know, the stress of just somebody sharing the secrets of their life with you is quite a responsibility, but then dealing with individuals who are in a lot of emotional pain, self-destructive, having suicidal thoughts, et cetera. But being able to be together and share the concerns helps tremendously. When you're isolated in your office, you don't have that opportunity. It could take a toll, and it can be a burden. So I urge mental health professionals to always reach out and keep an active dialogue among the individuals who are working on with the same individual that you're working with.
Case example, you have a patient we share, and the dosage was supposed to go from 37.5 milligrams to 50. And when I saw the patient subsequent to that, this person was saying, well, geez, 50 instead of 37.5, that must mean I'm really a mess. Huh? And I sometimes use humor. So with this person, I could, and I said, well, hold on, let me look this up. And it's to see if that extra amount meant you're crazy. So I looked it up, made believe I was looking it up. I said, nope, you're not crazy.
You never make believe you're looking it up. But you know what I do is I tell people, how many milligrams do you think is in an aspirin? And then I tell them it's 325 milligrams.
Oh my God.
And I said, so it's all relative. It's not the number of milligrams, it's the therapeutic range. And I make a point of letting people know for most medications what their therapeutic range is, so they have an idea of what's high and what's low.
The bottom line is we don't always appreciate how scary it is for patients to go see somebody like us. And
speak for yourself.
And that is why people, sort of put one toe in the water, and some don't go any deeper, and some people go deeper and deeper and deeper. But we are aware of that, and that's what we work with, and we appreciate it, and that's why we are talking about today resistance.
And that's why I'm Dr. David Gross, psychiatrist.
And I'm Dr. Andrew Rosen, psychologist.
And we are Two Shrinks and a Mic.
The Two Shrinks and a Mic podcast is for informational and entertainment purposes only. The views expressed are those of the hosts and guests and do not constitute medical, legal, or professional advice.
Please always consult a qualified healthcare provider before making any medical or wellness decisions. Our content is not a substitute for professional medical guidance, even though our mothers tell us we have the best advice possible.